Good afternoon, everybody. This is the Michael J. Fox Foundation for our Thursday webinars. I'm Dr. Maurizio Facarius. I'm a neurologist and a movement disorder specialist on the research program team at the Michael J. Fox Foundation. I'd like to welcome everybody to what it seems to be the largest ever attended webinar so far, so we are very excited. Today we are focusing on how Parkinson's affects the autonomic nervous system, which controls involuntary functions such as swallowing, heart rate, digestion, blood pressure, etc. We're joined today by a guest patient from New York who understands these complications. Also, joining us today is Dr. Charles Adler. Dr. Adler is a professor of neurology at the Mayo Clinic, Arizona. Thank you both for speaking with us today. Also, I want to thank Dave Iverson. You know all of him. Dave is our foundation's contributing editor and a member of our patient council, and he moderates our third Thursday webinars. Just as a housekeeping thing, I mean, you can log on every Thursday of the month from 12 p.m. Eastern Standard Time to hear discussion and ask questions about a topic important to the Parkinson's community. We hope you will mark this date on your calendar and you will join us each month. One final thank you goes to AstraZeneca. They are sponsoring this 2014 edition of this third Thursday's webinar, so that's very exciting and we're very grateful for that. Now I will turn the stage over to David, and let's enjoy this webinar.
Maurizio, thank you, and good morning and good afternoon, everyone. This is Dave Iverson. I'm really pleased to be able to join everyone and moderate this session today. As Maurizio mentioned, this is a topic that obviously has a great deal of interest. We've had more people register for this webinar than any of our others, and I think that's real testimony to the importance of taking up this subject. I think sometimes, you know, we all think, of course, of Parkinson's as a movement disorder, and it seems almost unfair, you know, it almost feels like piling on that there could be these other difficulties that come associated with the disease. But that's, of course, why it's so important to talk about them and to also talk about some promising new treatments. In fact, there was news about a treatment for one of those autonomic symptoms that we're going to talk about today, and also the way in which these autonomic system can provide perhaps some early warning signs for the disease. So it's important in various ways, both in terms of what we can learn about how these systems might provide an early warning device for diagnosing Parkinson's early, but also some really positive contributions that are now being made that can treat some of these difficulties. And as Maurizio also mentioned, we really want to take as many of your questions as we can. So if you will just use the question box on your screen and write your questions, in about a half hour or so we'll get to those. So let's get started, and we're going to begin by just giving a quick definition to repeat what Maurizio has said. The autonomic nervous system are those things that our body tends to do automatically: blood pressure, heart rate, salivation, sweating, food digestion, even sexual arousal. Those are all parts of what the autonomic nervous system controls. And some of these things then can provide problems within Parkinson's disease. And before we hear more from our experts, Dr. Facarius and Dr. Chuck Adler, we want to get a first-person point of view on some of these complications that can occur within Parkinson's and within the autonomic nervous system. And so Thelma, a Parkinson's patient, is joining us now to give us a sense of that. Thelma, thank you for participating in this conversation this morning.
Thank you.
And the first question I want to ask you is the point that comes up on the screen now, which has to do with the drop in blood pressure that can occur frequently when people stand up. I know that's something that you've experienced. Can you describe what that's been like for you?
Well, with the blood pressure fluctuation, you will get dizzy spells, you'll feel unsteady. It's a very uncomfortable feeling. You just are not sure, what's going to happen, when it's going to happen.
And has that been something that you've been able to get some assistance for when you've talked to your neurologist?
To help me personally, I've been doing meditation biofeedback with a mind-body psychologist. And she's kind of between my neurologist and the mind-body, the meditation. I do what they call mindful meditation. I've managed to help that somewhat.
And did you experience that problem with dizziness early on? Do you recall whether or not you maybe even experienced that before some of the other movement disorders?
Absolutely. When it started, they called it benign positional vertigo, and I had a difficult time driving. If I looked to the right when I was driving, I felt like the car was still moving. So I've experienced the dizziness and the low blood pressure, for many, many, many years, long before I showed any signs of Parkinson's.
It's really an important point, and one of the things we really want to key in on today. Another when under stress, like I had surgery, and when I came out of surgery, I had a blood pressure of 60/40 and stayed there for almost a week. Oh my, that is really low. Another symptom that often comes up for people, and again one that often precedes the movement signs of Parkinson's is constipation. And a number of people have already written in about this morning, Thelma, saying that that's a real problem for them. Was that also something for you that happened before?
For many years. And how I dealt with that was I put myself into the hands of a gastroenterologist, many years ago. And we kind of try to manage that. First we thought it was irritable bowel. We really didn't think Parkinson's as far as that was concerned years ago. But in reflection, that's been going on, it seems like forever.
And one other symptom that we want to mention that, again, is often a difficulty and is tied to the autonomic nervous system is swallowing. How has that been an issue for you?
Well, in the beginning, when we knew something was wrong, I had lost the ability to use my voice at all. So swallowing, talking, nothing. I couldn't communicate at all. I lost the ability to talk. I lost the ability to swallow. And what I've done is I go for voice therapy twice a week religiously. And in going for voice therapy, it's a very hands-on procedure. I mean, they're actually working with the muscles in your throat. And I've been doing that now, it's got to be about 4 or 5 years. And as I said, it's when she opens her calendar once a month, I'm in there twice a week. And I see her for about an hour and 15 minutes, an hour and 20 minutes twice a week, and that's what got my voice back. That's what helped the swallowing. It's been a full-time commitment.
Right.
I kind of feel it's almost like I'm on a merry-go-round, and I can't get the merry-go-round to stop when the autonomic nervous system is out of line. Before the medicine kicks in the morning. It's a terribly uncomfortable feeling, as I'm sure everyone listening to this will attest to.
Well, Thelma, thank you so much for giving us that first-person view of what some of these symptoms can be like. It's hugely helpful, and I think it sets up the kind of conversation that we want to pursue now for the rest of the webinar. So please stay with us. We may want to bring you back in for additional comments over the course of the hour. But let me also now fold into our conversation both Dr. Charles Adler, who again is a professor of neurology at the Mayo Clinic in Arizona, and Maurizio Ficaris at the Michael J. Fox Foundation, a neurologist as well. Dr. Adler, when you were listening to Thelma talk about these symptoms that we have up on the screen now, I'm curious about your sense of how common that phenomenon is, particularly this key point, I think, that many of these symptoms actually precede the movement parts of Parkinson's.
Well, I think that the issue of I'll say non-motor signs, so we all know that there's tremor and slowness of movement, difficulty walking, difficulty with balance. Those would be motor signs of Parkinson's disease. The issue of non-motor signs, including the autonomic signs, has become more and more important in terms of both understanding early Parkinson's disease and understanding the issues that patients deal with as the disease progresses. As far as early Parkinson's disease, or even before the motor symptoms develop, there are definitely autonomic signs, including constipation. There's good data from a number of different studies showing that constipation often precedes Parkinson's disease by many years. The issue of orthostatic hypotension or dropping in blood pressure is not usually as much of a problem early or before the motor symptoms, but certainly progresses as the disease progresses and can become much more of a problem later in the course of the disease. Thelma had some significant problems with orthostatic hypotension early in the course of the disease, so it certainly can happen. But I would say that's something I normally see in my practice a little bit later with constipation and some other issues preceding the motor signs, but not as much orthostatic hypotension.
And Maurizio Ficaris, there's been some news this week, and we should touch on that. We'll get to more of the various treatment options for all of these symptoms a little bit later in our conversation, but I don't want to miss the headline of the week, which is there's the FDA approving a particular treatment for orthostatic hypertension. Can you just give us the headline on that?
Absolutely. So that's actually a pretty good news because this drug called Northera, the active ingredient, let's say, is droxidopa, has been around for quite a bit actually in Japan first and then in Europe, but in United States we're sort of battling to get FDA approval, and that finally got approval on Tuesday. So last Tuesday, 2 days ago. The good news about this drug is that it's a drug that works, basically a precursor of adrenaline, and noradrenaline is a synthetic compound that is causing a little bit of increase in heart rate and a vasoconstriction. So there is enough to increase blood pressure and avoid that drop of blood pressure when you stand up. So that's a way to counteract orthostatic hypotension. As we reported in our blogs, in the press release has been reported as well. I think no, there's no press release. I think it's just like in the news, in the blog that we also had. But I mean, one important thing to notice is that obviously if we increase blood pressure when there's an orthostatic hypotension, so when we stand up, one of the counter side is that when we lay down, the blood pressure can go up and maybe go too high. So people are suggested to lean with the body a little bit inclined over, like maybe having a couple of pillows, thing like this, and be cautious maybe taking the drug earlier in the day rather than late at night. But this is fantastic news because so far very few other drugs have been proposed for orthostatic hypotension, and this just adds into that panel, and we hope that based on what we just said, given the prevalence of orthostatic hypotension in moderate and late, like in advanced Parkinson's disease, that we think might help a lot of people.
And Dr. Adler, anything else you want to point out about the treatment of that particular condition, what people ought to be talking to their own movement disorder specialists about?
So I think that there are a number of different things that patients should be aware of. First of all, Some patients may be on blood pressure medications, so antihypertensive medications, because early in their lives they had high blood pressure. So I think one of the first things to do is talk to the primary care provider or cardiologist. If you become lightheaded when first standing up and you have orthostasis, the cardiologist, the family practitioner may want to stop the antihypertensive medications. As Maurizio said, the second thing I usually do is elevate the head of the bed, put a couple of pillows under, or buy a wedge for under the bed, so that when you go from a lying down position to a standing position, the change in blood pressure is minimized. And I think it's important for everybody to understand that everything relates with the drop in blood pressure to gravity. So when one goes from a sitting or lying position to a standing position, all the blood drains down into the legs and the blood pressure drops. So elevating the head of the bed reduces that change in position. Another thing one can do is wear compression stockings. Compression stockings usually have to be worn up to the waist to compress the blood vessels and keep the blood up in the upper part of the body so that patients don't get lightheaded or dizzy. Increasing fluids and increasing salt are also very important treatments. And then, as mentioned, droxidopa is the new medication. There are a couple of other medications that we've been using over the years. One is called fludrocortisone. It's a cortisone medicine. And the last is called midodrine or midodrine. And both of those medicines can be taken to raise the blood pressure. And as Maurizio said, one of the absolute number one issues is to be sure that when somebody is lying down, the blood pressure does not go too high. So with taking these medications, it's going to be critical that patients have their blood pressure checked when lying down and then when standing up, because they definitely will raise the blood pressure, but you don't want the blood pressure to be too high when laying down in a bed, because that could lead to other medical problems.
And just one more question before we move on to some other points, because I think this is, you mentioned this, Dr. Adler, and I think it's important to underline. Amy writes in just now, everyone talks about low blood pressure, but I have high blood pressure at different times of the day. And so someone in Amy's situation obviously needs to be very careful about this. It's something that can go either way, and we don't want to be suggesting that everyone sort of go out and start taking droxidopa.
Oh, absolutely not. I mean, I think Amy brings up a really good point, and that's that blood pressure has to be checked multiple times during the day in multiple positions. And if there's evidence that there is high blood pressure at times, that's going to be extremely critical for trying to figure out what the best treatment options are. I will say that a lot of my patients will be seen by either internists or cardiologists. When blood pressure is fluctuating like Amy's is, it's often not the neurologist that will handle these issues, but a cardiologist may be very critical. And we always have to remember that every symptom or every sign that a patient with Parkinson's disease has is not necessarily due to Parkinson's disease. And it's always important as we talk about these other autonomic symptoms to make sure that there's not another reason why a person has that problem. And having a healthcare team is really very critical.
Let's push on to our next series of points, and we'll come back to not only high blood pressure, but we also will come back to the question of how you can deal with constipation, with swallowing difficulties. Selma had some interesting observations about the work that she's done on her voice, and we want to come back to all of those questions. But we want to get to next this question of what might be going on that could be the cause of all of this, and whether or not there's a common denominator that may be in play. And so, Maurizio, if you would, tell us a little bit more about this next point, because one of the things that may be going on with these autonomic dysfunctions is the protein alpha-synuclein, which we already know is in play in the brain when it clumps up and forms Lewy bodies, that's part of what goes awry in Parkinson's in the brain. But we're discovering that protein is in other places. What's the thinking about whether or not that may be something that is causing some of these autonomic dysfunctions?
Right. So let me try to do this sort of introduction first. And I want to just piggyback what Chuck Adler said before. There are symptoms like orthostatic hypotension, bladder problems, etc., that might come up later in stage, whereas other like constipation may come up earlier in stage. And one of the theories is that if for some of the symptoms you need sort of a brain control, and that we talked about this in previous webinars, but beyond the dopaminergic degeneration that happens in the Parkinson's brain that involves motor symptoms, we have other neurotransmitter and other systems involved in Parkinson's, and those systems are also degenerating with time and might be responsible for some of these non-motor symptoms. Whereas other symptoms are maybe less related to the brain itself, but they might be more involved because of an involvement of the peripheral nervous system. So the nerves that are beyond the brain and the spinal cord, but they are connecting tissues and organs. And what you just said, Dave, I think is perfectly in line with the line of research that Dr. Adler is actually conducting, which is finding these clumps in the periphery. So not only in brain, as you said, but also in peripheral system. So if we find those clumps and we find those pathological hallmark of Parkinson's also in the peripheral system, that might, and I again underline might, be a common cause of not only the motor symptoms, because we find those clumps in the dopaminergic system that is degenerating, but also in the periphery, and might be responsible for some of these non-motor symptoms, including constipation and gastric motility. So that's where the connection is. That's where I think there is some sort of support from the research, and I would love to hear Chuck Adler's point, because this is something that he has been extensively studying, and we are very grateful to him for his research.
So, Dr. Adler, we're now finding, as Maurizio is suggesting, for example, that alpha-synuclein is in the gut. I guess what we don't know yet is whether or not that's actually what's causing the constipation. Is that the link that we're still trying to understand?
Yes, it is. There is no question that when we look at various different organs in the body, there is alpha-synuclein in many of those organs, in nerve fibers in many of those organs, including various areas of the gut. And the esophagus, the highest part of the gut, which is up towards the mouth, has the highest density, the most amount of the synuclein. As one goes lower in the gut, into the stomach, into the small intestine, into the large intestine, the amount or the density becomes less and less, but is still present. Whether that's the reason why patients develop difficulty with constipation or not is still unclear. It's unclear whether this issue with the GI system is related to the brain and the spinal cord or the alpha-synuclein in the gut, and that's definitely being worked on. The finding of the alpha-synuclein in the gut and in various glands, we found it in the submandibular gland, which sits under the jaw. It's found in other organs, has led to the possibility of doing a tissue biopsy to diagnose Parkinson's disease. And so knowing that synuclein clumps in these different organs is critical to both what may be causing the symptoms as well as the potential to make a diagnosis.
I want to come back to the diagnosis question in one moment, but just to be clear also, alpha-synuclein is in everyone, right? It's not just in people with Parkinson's, and that's part of the mystery here, is sort of whether it's good and what might it turn it to go bad. I mean, there's still so much that we don't quite understand about what this common denominator throughout our systems does and what causes it to become toxic.
Correct. I mean, there's no question alpha-synuclein is all throughout the body and is a normal protein. there are chemical changes that occur to it. It becomes phosphorylated, meaning there's a phosphorus that gets attached to it. And then there's clumping. Certainly in their brain there is clumping of this protein. And what makes it clump, whether clumping is a secondary issue or whether that's the primary reason that patients develop Parkinson's disease, is very much unclear. It appears that the clumping of this type of synuclein damages nerve cells. That's been found in cell cultures and in animal models. But translating that into we as human beings and being sure that that's the cause remains unclear.
And this takes us then to the next point we want to make, which is that, as we've already discussed, some of these symptoms may precede the motor symptoms, like constipation in particular. And to the point that you were just making, that this may actually, in some ways, provide some good news, and that it may provide us a way to get in on the disease early. And we all know that early diagnosis could be so key to making more progress in managing the disease. And you touched on this a moment ago, Dr. Adler, about the tissue biopsy possibilities. So tell us a little bit more about that. If someone is, let's say they're having some of these early warning signs, perhaps it's sleep disruption or loss of sense of smell, which is not an autonomic problem, or perhaps it's constipation. The idea then that you could do a tissue biopsy might help us confirm a diagnosis earlier on. What might that be able to tell us?
So the work that we've done with tissue biopsies of the gland that sits under the jaw, called the submandibular gland, has so far, the majority of that work has been in patients with more advanced Parkinson's, so people who have had Parkinson's for more than 5 years. We've done a big study in people who have come to autopsy, so we know that every patient that we've autopsied and looked at the submandibular gland, this alpha-synuclein protein is present in the nerve cells of those submandibular glands. Then we did a study looking at tissue biopsies, so we did a needle biopsy of the submandibular gland, and most of the patients that we biopsied had the protein in their submandibular glands. Currently, the Fox Foundation is funding a study where we're looking at early Parkinson's disease, so people with disease less than 5 years. And once that study is complete, I'll be able to give results, but being able to make a tissue diagnosis would be extremely important for many different reasons. Obviously, when we try to diagnose cancer, when we try to diagnose many different diseases, the best way is to look at the tissue and actually see the abnormality. Otherwise, we're just relying on clinical signs and symptoms. So by having a tissue diagnosis, we might be able to use better treatments. If we have an early diagnosis even before the motor signs, and I'm not saying that this salivary gland or submandibular gland biopsy would give us that at this point, but if it did, we'd be able to potentially start disease-modifying treatments even earlier because it might precede the motor signs. That would be our hope, but at this point, the research still needs to be done.
So we want to now plunge into really the meat of our conversation about what can be done with some of these symptoms and the kinds of things that people are concerned about. We've already talked some about hypotension. We can take more questions about that and the drugs that both Dr. Fikaris and Dr. Adler have mentioned, and we now want to get into some of the things that can be done for some of these other problems, such as constipation. And I want to start taking all of your questions. So do type those in, and we'll try to get to as many of them as we can. And the first one I want to take, Dr. Adler, that I think is such a key question, and this comes from Janet, who writes in, how do you know what symptoms to talk about with your physician, and whether or not you should talk about them with your family physician or with your movement disorder specialist? I think it's such a key question because we're learning that so many things that we didn't think necessarily were connected to Parkinson's might be, but also, as you point out, not everything that you're experiencing necessarily be connected to Parkinson's. So what would you say to Janet about who do you talk to about which problem?
So I think that's a great question. So the first recommendation I have is that you write down all the questions you have, because a lot of times when patients come into the office, they forget what they want to ask about. So the first thing is write them down. Second thing is all of these symptoms that we talk about, I think it's worth talking to both the primary care physician as well as the neurologist or movement disorder specialist. I think that, as mentioned before, a lot of these non-motor symptoms are related to Parkinson's disease, but they may well not be related to Parkinson's. They may be, in some cases, medication side effects. They may be, as I mentioned, with antihypertensive medicines. They may be issues that would be easy to solve by the primary care doctor. I would say talk to both doctors, and then hopefully the two physicians can work as a team in trying to address the various issues. It's often not clear whether something is a Parkinson's sign or whether it's a sign of something else, and that's why having both sets of physicians dealing with it becomes really, really important. How do you know which symptoms to broach? I'm a firm believer that if there is a symptom, it needs to be broached, even if it's just as simple as, is this due to my Parkinson's disease? I think that any symptom or sign that you as a patient have and have concerns about should be broached with one or both of your physicians.
You used the expression to me in an interview we did not long ago called doorknob diagnoses, that too
Right.
often these things sort of come up as someone's about to leave the room, and that it's really important that those questions be asked by physicians, and that it's a sort of joint responsibility, that people need to engage in that conversation.
Correct. I think we as movement disorder specialists have increased the number of questions that we've been asking our patients related to the non-motor signs. I know my practice when I see a patient is way different today than it was 15 to 20 years ago when everything concentrated on the motor features. So I think I hit on a lot of the questions that patients have even before they ask their questions. But the one thing that I find that's very critical is that while the person is sitting on the sofa, on the chair in the doctor's office, that the questions all be asked rather than just as you're walking out the door, oh, by the way, I get very lightheaded when I stand up. And then the next thing you know, that needs to be a few-minute conversation as opposed to just I'll see you in a few months. So I think it's really important to try to address all these things. Again, I think the movement disorder docs are starting to address many more than we used to address in the past. But I think having a list of your questions and going through them before you stand up to leave is really critical.
And let's get to more of those questions. A number of people, Marito, asking about constipation, whether or not there's something specific that can be done, whether or not there's something different about that problem in Parkinson's than in sort of everyday garden variety constipation. There's this thing called Move PD that we wanted to bring up. What can you tell us about what can now be done that's useful for patients who are struggling with that?
Right. So, well, I would start to your point, Dave. I mean, what is in the real world solutions? Like something that we have already available that we can advise to people with constipation. And Chuck actually mentioned water before for hypotension. I would say that water is actually something really important for almost everything, including constipation. So my first recommendation would be increased fluid intake that helps soften the stools and allows a more like an easier voiding of your intestine. So that's something really important to do. Funny enough, we have been talking about this extensively, but exercise is also a very good point, and it's a very good, a recommendation for many of the things, both like we mentioned before, hypotension, but as well for constipation, because it allows people to keep, the whole constant movement and facilitates constipations, avoiding. Sorry. Then several other things are among stool softeners, eating, having a good a diet equilibrated, like a balanced diet when it comes to vegetables and fibers. So getting fruits and vegetables in good portions during the day, that also facilitate avoid constipation. There is a specific fiber called psyllium that is being used in extensively also to reduce constipation. When we go, and those are all easy day by day, over the counter or just simpler remedies. But we understand that Parkinson's patients go way beyond that. So there are a few medications that can be used, like lactulose or other osmotic solutions. Are unfortunately one of the things that we need to be very careful about is that those kind of medications cannot be taken constantly. So we just should be done for a reduced period of time and then leave, sort of basically go back and educating your body with all the natural remedies that we just mentioned. But the foundation, and that's something that you mentioned earlier, Dave, is now considering and supporting two different studies that are focusing on specific targets that should improve not only colon motility, so reduce constipation, but also gastric motility. And one of the reasons why we care so much about it is that we mentioned that in the past as well. If the food transits faster in the stomach and as well, than in the intestine, that also could improve the absorption of the medications that we take, specifically levodopa, where most of the people are taking levodopa for Parkinson's disease. So I would say we are focusing on these two specific studies right now. One is called, as Dave mentioned, MOVE-PD. That's a funny name, and I think it just reminds us, for the movements of the intestine. This is a study that the company Rhythm is developing, is a ghrelin agonist. So it's a specific molecule that is targeting this receptor in the intestine, and it is moving, it is making the motility of the intestine to go faster. Actually, that's it. This is a drug that's been used in diabetes for gastric paresis, and is now repositioned in the Parkinson's world for severe constipation. And again, two major outcomes here that we're looking for. One is to improve the constipation. The second is to see whether the absorption of the currently taken medications can be also improved. The second study that the foundation is supporting is a study against another receptor called motilin. So again, it reminds the movement, motilin. This is a compound developed by GSK, and we are supporting their study in the United Kingdom in this moment for a motilin agonist, and again, developed with the purpose to improve the motility of both the colon and the stomach. So, and I will stop here, but those two, unfortunately, are in now clinical testing. So they're not in the real world right now in terms of they're not available to everybody, but they will hopefully soon be available for everybody. And all the other ones that I mentioned earlier are already available for everybody.
And Dr. Adler, Richard raises the questions about whether or not the drugs that you take for the movement part of the disease, the movement disorder part of the disease, have an effect on autonomic dysfunction. And I guess you could take that question either way. In other words, are any of the movement disorder drugs, whether that's levodopa, carbidopa, agonist, whatever, helpful, or do they perhaps cause other problems? Are they part of what prompts the constipation problems?
So the medicines for Parkinson's disease all have the potential to cause some of the problems. It's certainly We've seen that dopamine agonists, levodopa, can cause constipation. They can cause lightheadedness on standing. They can cause sleepiness and difficulties with sleep issues. In some cases, they may actually help some of the non-motor symptoms, but in general, the Parkinson's medicines do not help non-motor symptoms, and if anything, they can possibly make it worse. All of that's trial and error, meaning that you see what happens once those medicines are started for the motor symptoms and watch the non-motor symptoms as the medicines are changed around and the doses are changed.
Lisa wants to know about urinary problems, incontinence in particular. Dr. Adler?
So urinary or bladder issues can become frequent problems, especially as the disease progresses. Urinary incontinence, urinary frequency, and urge to urinate, and even nocturia, which is awakening more than 2 times per night to urinate. All of those are issues that patients with Parkinson's disease face. In terms of how to deal with it, number one, as mentioned before, I always like to be sure that there's not something else going on. So a good examination to be sure there's no evidence of other neurologic problems, and in some cases sending patients to a gynecologist, urogynecologist in the cases of women, or urologists in the case of men, to try to determine and be sure that there's not some other medical problem that's at work. If it's nighttime issues, the first thing I always do is restrict drinking of any fluids after maybe 6 or 7 o'clock at night and try to reduce the fluid intake at that point. And then there are medications that can be used, such as oxybutynin and tolterodine and a number of different medicines that are called anticholinergic medications. One has to watch for side effects: dry mouth, blurred vision, difficulty concentrating, difficulty with cognitive functions, actually difficulty urinating in some men as well. So there are medicines available for the urinary incontinence or urinary frequency, et cetera, but one has to be careful with them and be sure that it's a Parkinson's issue and not another issue.
It seems like Dr. Adler and Dr. Ficaris both that unfortunately these can go either way. You know, we've talked about both high blood pressure and low blood pressure problems that, you know, can, and we have 2 questions right now that have come up. One person asking about how can you stop excessive salivation, stop drooling. Another person saying, what about having too dry a mouth? Do you see both, Dr. Adler, and then Maurizio, chime in on this as well? Are they sort of 2 sides of the same problem? What's going on with that?
So in general, patients with Parkinson's disease would be more likely to have too much saliva or drooling rather than have a very dry mouth. The first question I would ask regarding a patient who told me about dry mouth would be, what medicines are they on? Because as mentioned before, some of the medicines can cause dry mouth and really dry one up. In terms of too much saliva and drooling, it's unclear whether this is just a motor sign, meaning that patients with Parkinson's don't swallow as often, or if there's some other underlying cause for it. In terms of drooling, there are definite treatments one can use for drooling. First of all, the Parkinson's medicines sometimes can be helpful. So this is a case where carbidopa, levodopa, and dopamine agonists may help. Then there are the anticholinergic medications that I mentioned earlier for the bladder. One of them is called Robenol. There's the scopolamine patch. Sometimes can help with drooling. And then in some patients, I'll use botulinum toxin injections. And there are 4 different toxins out there: Botox, Myoblock, Xeomin, and Dysport. And these drugs can be injected into the saliva glands and often will be very helpful in drying up the mouth. So a lot we can do for drooling. It would be rare, as I said, other than from medication side effects, that I would see dry mouth in Parkinson's.
And let's talk a little bit more then about the question of swallowing, which would seem related perhaps in some ways to salivation. And Thelma spoke eloquently earlier about some work that she's done with voice in particular. But Maurizio, what are some of the new, what's the new research telling us about that sort of strength training and also about deep brain stimulation, which we normally think of as being something that can be helpful with certain aspects of the movement parts of the disease, tremor perhaps in particular. What are we discovering about that?
Oh, so the funny thing is about and I think I would just reconnect to what deep brain stimulation does as a therapy to start with. So I start with your second question, Dave. So deep brain stimulation works on the same pathways that are involved in the motor symptoms. So so one of the questions that also came up before was, would deep brain stimulation help with the autonomic dysfunction or with other symptoms like that? And my sense is that the short answer is no. So deep brain stimulation is an alternative to motor symptoms, and as I said before, it works on those pathways that are involved in the motor function. But unfortunately, some of those, specifically when it comes to swallowing or to speech, they're not responsive, to not always. I mean, Chuck actually mentioned some of the swallowing problem might be responsive to levodopa, but not necessarily. And what we know for sure is that speech doesn't seem to be responsive. Actually, in fact, could be also impaired or impacted by deep brain stimulation. So I honestly don't think that that venue could help when it comes to swallowing problems or speech therapy. What we know for sure is that there are several techniques that are now working on improving speech. And so, I think, we can just go back to what our gas patient, Thelma, told us before in terms of, the therapies that she followed. But there is the full techniques about, improving voice. There are several there, and then we're being supporting some of those programs out there. They're going from pure exercise for the voice in terms of doing movements with the voice, strengthening increasing the potency of how we emit sounds, to also creating specific devices that are put in the in the ears that basically create a background noise, forcing people to shout out loud. So one of the things that we realized is that Parkinson's people think they're speaking loud, but they're not. So there's a lot of issues about just making themselves understood, not because they're not generating the words, but because they just don't use enough volume or enough power. So by creating a background noise that sort of forces people to speak louder and then make and then salivation and speaks slower helps make things more clear. So those are some of the studies that we are supporting and that we are interested in, but there's no current a medication to improve, for example, no drug, let's say, to improve speech or speech. For salivation, I would just like to add that we are also supporting another study who is developing a small, dissolvable film, a sort of a Listerine version that just you can put on your mouth to reduce saliva, but that again goes on the same category of drugs that Dr. Adler mentioned before, and that can be a relief for a few of the people that have drooling and excessive saliva, but might also be, have some drawbacks in terms of other cholinergic or cognitive issues that can come with the longer use of those medications.
And Dr. Adler, anything you want to add on swallowing, strength training, voice, any of those sorts of issues?
No, I think Maurizio covered it. I would say, though, that in general, I would not think of those really as being non-motor issues or autonomic issues. To me, those are mainly motor problems as opposed to autonomic problems.
And on that point, because it is complicated sometimes to separate which is which, a couple of people have brought out questions about sense of smell, and that's also not part of the autonomic system, but it's another one of those early warning signs, right, Dr. Adler?
Correct. I think that loss of the sense of smell often precedes the motor signs of Parkinson's disease by many years, and there's some research to suggest up to 7 years prior to the onset of the motor signs, people may lose their sense of smell. Sense of smell is one of those things that is being tested as a very early marker of Parkinson's to try to identify people who are at risk of developing Parkinson's disease. We and many other groups are using smell as a screening tool for various different research programs. In terms of what causes the loss of sense of smell, the current belief is that it is probably due to alpha-synuclein in the olfactory bulb. That's the area of that intakes smell just above the nose. And so there is alpha-synuclein that is present there, and actually that may be the first location for alpha-synuclein to be clumping anywhere in the nervous system. In terms of what else does that do, well, by losing the sense of smell, Parkinson's patients may lose their sense of taste, and by losing the sense of taste may lose appetite. And so that may be one of the causes of some of the people with Parkinson's having some weight loss. Unfortunately, there's very little we can do. There's really no treatments for improving the sense of smell. Some patients will say after they've been put on the Levodopa or a dopamine agonist that their smell seems to improve, but there's no research data to show that there's improvement if we test the sense of smell. And so, unfortunately, once a patient loses smell, it often remains gone.
Elizabeth also asked a question about lack of appetite and thus loss of weight. Is that the general thinking then, Dr. Adler, that the lack of appetite and weight loss, which many people do experience, is connected to that olfactory problem?
Very hard to tell. I think that it's a hard thing to tell and a hard thing to study because almost all patients with Parkinson's disease do lose their sense of smell. So then knowing why those who have Parkinson's lose weight and others don't, it's hard to use smell as a differentiating point because if everybody loses their sense of smell, everybody should lose weight. There are a number of different projects ongoing right now looking at GI motility, looking at the possibility that there's bacteria in the stomachs of people who lose weight compared to those who don't lose weight. And so I think that the jury is out in terms of why certain people with Parkinson's lose weight and others don't.
Lots of other questions. We'll try to get to as many as we can in our last 6 or 7 minutes here. Maurizio, maybe you can field this one. Melinda wants to know about difficulties in relating temperature control, sometimes feeling hot, sometimes feeling cold.
Yeah.
Again, not sure if that's connected necessarily to autonomic function or not, but what do we know about that?
Yeah, so I would say actually there is a little connection on that, and I'd just like to go back to your previous question, which is sometimes we have more of something, sometimes we have less of something, sometimes we have excess of sweating, for example, because of thermal control. So, the Melinda's question is pretty spot on. I mean, it's like a lot of people are either too sensitive to high temperatures, and and their sweat pattern changes over time. So maybe there is like a excess sweating overnight or during the day, and that was not present before, or now they becomes too sensitive to cold temperatures. And now and again, I think, and I unfortunately, I don't have a pure understanding of the pathological mechanism that happened, but my way of describing would be that in the brain when we have the subtle degenerations, and then unfortunately we know that Parkinson's is a progressive disorder. So with time, those degenerations are affecting several other systems that not only going on the control of the bladder or the control of how we regulate blood pressure, etc., but also they go on the thalamus, for example, or other area of the brain that are they're responsible for sensory issues, including like the way that we feel about temperature and hot and cold temperatures. So that impairment is reflected in several ways by either a higher sensitivity or a lower sensitivity to sun temperature, and as well the sweating. And I bring up the sweating because that's something that in my previous experience in seeing patients was coming out pretty often actually, and it was related, I think, is also a regulation of the way that the blood vessels are constricting and releasing. So it might be also connected to the way that the autonomic system works.
And Dr. Adler, anything else on Jan just added a question about what about extensive sweating, especially at night? Any recommendations for Jan?
So I would definitely add that one of the things I've seen is that the feeling of cold or the sweating issues can often be a sign that the medication has worn off or that somebody is on. So patients with motor fluctuations where the medicines kick in and wear off may see signs of sweating or feeling cold in one or the other state. And therefore the best way to treat it is keep them in the on state if that gets rid of that sign. In terms of excessive sweating, again, there is medication that can be tried. The one I usually use is glycopyrrolate. Is probably the first one that I try for excessive sweating, with the main concern is, as with all these anticholinergic medications, dry mouth, blurred vision, trouble concentrating, trouble urinating, and so it's just a matter of balancing benefit with side effects with a lot of the medications that we use for non-motor symptoms.
Two more questions, and then I have a last question I'd like to pose to both of you. Jim asks whether or not there's any question between Parkinson's and hearing loss, and Sam asks Dr. Adler about the connection to the optic nerve. There is work recently about eye movement and Parkinson's, but Chuck Adler, can you comment on both optics and hearing?
So hearing loss, the answer would be no. There's no known relationship between Parkinson's and hearing loss. In terms of optic nerves, certainly patients with Parkinson's disease can develop difficulties with vision, blurred vision, double vision, different difficulties seeing in low light. But as far as we know, there's no optic nerve abnormality. There may be trouble with the retina, which is the lining of the eye, and we're doing some work on dopamine and the retina. But in terms of there being an issue with the optic nerve itself, there's no clear issue with that.
And just one last quick one, and then I'll pose my last question. Rachel wants to know about difficulty of swallowing. So then how do I take my medication? It's actually a really good question, Dr. Adler.
Excellent question. So in general, some of the medication can be crushed, especially carbidopa, levodopa, and put in a little bit of liquid and then swallowed. It will work a little bit faster. It may not last as long. There is the rotigotine patch, so it's possible to get a dopamine agonist that's not in a pill form, but is a patch that gets put on the skin. In pretty advanced cases, we have the ability to inject a drug called apomorphine, which is a very short-acting dopamine agonist. But the goal would be to try to be able to get people to swallow. If swallowing is so severe that somebody can't even swallow pills, that's certainly a point in time where we talk about having a feeding tube placed. And because if somebody can't swallow a pill, then that means they're probably not getting enough nutrition by mouth, and putting a gastric tube or a tube into the small intestine likely is going to be the way to go.
Yeah, if I can, Dave.
Yes,
if I can just chime on this because I think is very spot on, like Rachel's question again, and Chuck mentioned all of that already, but the foundation is really interesting in learning different ways of deliver drugs because of this specific reason. So, Chuck mentioned rotigotine, which is a dopamine agonist, mentioned apomorphine, which is also a dopamine agonist, but we know that levodopa remains one of the gold standard therapy. I mean, it's the one that has been proven so far with the best efficacy for Parkinson people. So we're working on alternative ways of deliver levodopa to patients, and one of those could be again through the skin. So we are supporting a program that is developing a pump patch. We are supporting a program that is delivering levodopa via an inhaler. So we are working on different pumps. So all of those are obviously just to bypass the issue, not only for the swallowing, but also for the digestion and the issues of the gastric motility and the constipation that we mentioned before. But those are really important issues that we're trying to overcome with our research.
We should mention there's a drug called Parcopa also that can be taken and dissolves under the tongue. So it is a carbidopa levodopa formulation that you can get, and it just dissolves under the tongue and does not need to be swallowed. So that's also a possibility.
Correct.
We're at the end of our hour, and let me just ask you, Chuck Adler, for a last comment. And I'm going to ask you to comment actually on a point that Cindy makes, which I think is actually a great way to bring our conversation to a close, which Cindy writes, now that we know more about the non-movement symptoms, maybe we should rename movement disorder specialists. And I like the point because I think, Chuck Adler, it comes back to really what you're saying, that we really need to talk about all of these things. Whether you're talking to a movement disorder specialist or your family physician, we have to talk about non-movement questions as well as the movement questions.
So I would say that pretty much all movement disorder specialists are neurologists first. So all of us did our neurology training. So we subspecialized in the treatment of and diagnosis and treatment of Parkinson's disease and other movement disorders. So I think movement disorder specialists, that term won't go away, but we've always been Parkinson's disease and movement disorder specialists. I think that our awareness has really changed over the years, and the one thing that all doctors need to do is make sure they stay up with the times. Whatever it should be, all of us need to be up on all the new aspects of these diseases, treatments, and whatnot. And I don't see the term movement disorder specialist going away at this point, but please keep in mind all of us are neurologists and do much more than just movement disorders.
And again, important to bring up all of these points, both movement and non-movement, when you do see your neurologist. I really want to thank Dr. Chuck Adler and Thelma, who got us off to such a good start by framing what these issues mean from a first-person point of view as we conclude our conversation. And Maurizio, I will hand it back off to you to wrap things up. And just a reminder that we will be back again the third Thursday in March when our next third Thursday seminar will focus on how Parkinson's may be connected to other movement disorders, Huntington's disease, and other movement questions. So we'll explore all of that in our next one. But back to you, Maurizio.
Well, thank you very much, Dave. I just want to close with a positive thing that I'm just came out to my mind. It is true that all movement disorders now are focusing on also non-motor symptoms. But let's face the fact that if we are focusing more on non-motor symptoms, it's because the motor symptoms seems to be better treated now than they were before. So I think is a good piece of information. Levodopa has been out for almost 50 years now, and but at the beginning, the motor symptoms were so severe that we're basically shading off all the non-motor symptoms, and now we're getting into a better control of those motor symptoms, and people are recognizing more and more the non-motor, which are also, if not even more, equally impacting the quality of life. So obviously, we will focus on those. We will try. Our mission is to find a cure, but also to improve the quality of life of everybody with Parkinson's disease right now, and focusing both on motor and no-motor symptoms. So I think it's just a positive reminder to everybody. But I just want to really thank everybody for participating. I want to thank you, Dave, for moderating this, a very interesting session. I want to thank Thelma for participating. I want to thank Chuck Adler for his brilliant, even like dissemination and examination of what is out there, and I really enjoy his research line. So we will see more about alpha-synuclein in the periphery, especially in the salivary gland and in the gut. So hopefully we will learn more about that. We will be sending a link to the webinar on demand to listen again or share as you like. There will also be a survey link in the email. So we hope that you'll share your thoughts on today's presentations. If you have any additional question or something that we were not able to answer, we will try to get back to you in that format. I just want to remind, as Dave said, to mark your calendar for the third Thursday of the month, March 20th at 12 p.m. Eastern Time. Again, we will be talking about Parkinson's disease related to other movement disorders, like what does Parkinson's have to do with Lewy body dementia or multiple system atrophy or progressive supranuclear palsy. So just to name a few. So you can get every information visiting our website at www.michaeljfox.org. And I think with this, we just want to thank you again, and we wait for you. Like I was just looking forward to getting reconnected in a month. Thank you, everybody, and have a great rest of your day.